The rationale for patient skin antisepsis is to clean and disinfect the skin around the surgical site, preventing infection. Chlorhexidine in different concentrations and different combinations is commonly used. In 1.5% concentration, in combination with cetrimide, to clean contaminated areas such as the vaginal mucosa. In 0.5% concentration in combination with alcohol to clean and disinfect the skin. In 0.5% concentration with alcohol and a tint, when cleaning, disinfection, and tinting or painting of the skin are required. Where the use of chlorhexidine is contraindicated, povidone iodine may be used. In this film, cleaning and draping techniques will be demonstrated on different parts of the body using a patient model. To expedite instruction, chlorhexidine with tint will be seen used only on the abdomen. Elsewhere, the area to be cleaned will be demarcated using a highlight, and cleaning then simulated as shown. This allows the view of landmarks and structures to be maintained. Surgical draping techniques and types vary widely between hospitals and procedures. The objective, however, is always the same, and that is to build a sterile field upon which surgery can safely be performed. In this film, disposable adhesive drapes will be used to show a number of techniques. Patient skin antisepsis and draping requires a sterile field. For a more detailed elaboration of how the field is set up, refer to the course Table Setting, Basic Instruments and Disposables. Take note of the OR furniture, a kick bin, a Mayo stand, and OR trolley on which clean implements and drapes have been prepared. Take note of the drapes, sterile gauze swabs, clean container, and clamp. An example of how to load the clamp is now shown. A gauze swab is folded and then placed into the teeth of the clamp. This can then be used to clean the patient. Take note of the scrub nurse and the surgeon. This distinction is made purely to help describe the actions. The preparation and draping will first be demonstrated on the abdomen. Having prepared the cleaning solution and clamp as previously demonstrated, the scrub nurse passes both to the surgeon. Take note that positioned in this manner, both the patient and the surgical table are not sterile. The parts of the body that are not involved in the procedure remain covered to keep the patient warm and maintain their dignity. The exposed area to be cleaned should first be inspected for abnormalities, such as broken skin. Hair removal may be required. The sterile team members maintain a safe distance from the unsterile area. The skin can be cleaned with a number of different patterns. Whatever the pattern, the principle is to start around the incision site and cleaning the skin adjacent to it first. Thereafter, cleaning the skin away from the incision site. In some parts of the body, there are dirty and clean areas. On the abdomen, the area around the umbilicus is considered clean, while the umbilicus itself is considered dirty and is therefore cleaned last. With this principle in mind, observe how the abdomen is now cleaned. As previously mentioned, chlorhexidine with tint is used, starting with the skin around the umbilicus and adjacent to the incision site, and then spreading to the skin away from the incision site. Once this is done, the rest of the abdomen is cleaned in the same manner, bearing in mind the umbilicus is considered a dirty area which should be cleaned last. Take note of the even movements of the clamp and that there is no splashing of chlorhexidine solution during the procedure. With skin disinfection concluded, the swab is disposed in the bin, while the clamp and container are handed to the circulating nurse. For this midline incision of the abdomen, a square draping configuration will be used. The tint in the cleaning solution clearly demarcates where the skin has been cleaned. The square draping configuration therefore creates a more or less four-sided shape within the clean skin, a safe distance away from the not clean skin. Drapes are now used to build a sterile field around this shape. A safe distance is maintained, the drape unfolded and the adhesive part uncovered. The drape is handed over above the table. Take note of the distance between the drape and the unsterile area below, and of how both OR team members try to minimize contact with the adhesive strip of the drape. The single drape is unfolded by the surgeon on their own, as shown. Once unfolded, it is applied to the patient's side. Take note of how the surgeon maintains a fold at the edge of the drape to avoid touching the patient. The scrub nurse then does the same on the opposite side. Unfolding is performed in a manner that avoids contamination. In this instance, a little difficulty is experienced, but the scrub nurse waits until the drape is completely unfolded before applying it to the patient's side. Two sides of the square configuration are now in place. The scrub nurse and surgeon now work together to unfold a larger drape. Their coordinated actions intended to minimize the risk of contamination. In contrast to the smaller drape, this larger drape is first applied. The additional adhesive strip covers removed, sticking it to the smaller drapes underneath. This larger drape is then unfolded, extending the sterile field. Another large drape is used to perform the same action, and completes the creation of the square draping configuration. Take note that typically this larger drape will be placed over an anesthetic stand surgical table accessory. This was not done in this film to allow maximum visibility. Square draping of the abdomen is now complete. When draping for head and neck surgery, such as a thyroidectomy, consideration needs to be given to airway devices which may be present. Here, intubation of the patient has been simulated. In working to clean and drape the surgical site, the sterile team must maintain awareness of the airway device and maintain good communication with the anaesthetist. The skin is disinfected, starting over the incision site and adjacent skin, and then working away. Care is taken not to dislodge the ET tube. As with the abdomen previously, a square draping configuration is used. Take note of how the scrub nurse remains aware of her surroundings as the first small drape is handed to the surgeon on the opposite side. It is unfolded and applied to the patient as shown. Take note of how slow, firm movements are used to secure the drape onto the patient and adjustments kept to a minimum. The second drape is positioned by the scrub nurse in the exact same fashion. The third drape is a large drape and is put into place by both the surgeon and scrub nurse, and then unfolded to expand the sterile field. Attention is now turned to the final large drape. Placement of this drape requires the assistance of a member of the anesthetic team. To avoid sticking the drape to the tube, a gauze swab is used to separate them. As the still folded drape is lowered into position, the anaesthetist places a swab over the length of the ET tube, allowing the drape to be appropriately positioned without sticking to the ET tube. This prevents accidental extubation of the patient at the end of the procedure when the drapes are removed. The anaesthetist maintains control of the ET tube as draping is completed. Again, take note that normally an anesthetic stand would be present, but was not shown in this film to aid visibility. Square draping of the neck is now complete. When performed for cancer indications, breast surgery may be accompanied by a sentinel node biopsy. The affected breast and ipsilateral axilla require disinfection and cleaning. The area now highlighted requires cleaning. Take note of the patient's midline. Cleaning and draping are performed across the midline, allowing for maintenance of orientation. First, the chest is disinfected using the same principles as previously mentioned. Cleaning of the arm is performed with the help of an assistant. The assistant raises the arm. Both he and the arm support are not sterile, and he must position himself in such a manner as to allow the scrub nurse to work without the risk of contamination. Cleaning progresses circumferentially, and because it is the least clean area, the axilla is cleaned last. The assistant gives the scrub nurse space to position the unfolded drape. With that drape fully unfolded, the scrub nurse positions it over the arm support and tucks it underneath the patient. Only once the scrub nurse is safely out of the way does the assistant then carefully place the arm onto the drape. In this film, the same assistant then scrubs in to assist with draping the chest and arm. A third person may also do so. To drape in this manner, a version of the square configuration is used. A smaller drape is positioned on one side of the surgical site. With this smaller drape in place, a larger drape is positioned at the caudal end of the surgical site. A second large drape is then used to cover the head. With draping of the chest complete, the final small drape is used to place over the arm. Draping for a breast and axilla procedure is now complete. Surgery on the upper limb may be performed at any point along its length. In this film, cleaning and disinfection of the forearm as well as the hand will be demonstrated, as well as 2 draping techniques for the same. To clean the surgical site, the arm must be lifted by an unsterile assistant. This is done with spatial awareness that allows scrub nurse and surgeon to work without the risk of contamination. In this instance, the entire extremity is considered to be clean, and the disinfection progresses in a proximal to distal direction, with the assistant rotating the arm to allow the entire circumference to be cleaned. The hand is cleaned as shown. To clean in between the fingers, a gauze wick held between 2 clamps can be used. The use of the gauze wick is now demonstrated in close-up view. With cleaning completed, the arm can now be draped. As previously demonstrated, first, a large drape is placed underneath the arm. Once the scrub nurse is clear, the assistant lowers the arm and makes room for draping to continue. Working in tandem, a large drape is positioned over the proximal arm. Once fixed to the patient, the sterile field is expanded and simple draping for the upper arm is complete. An alternative to this configuration is an extremity sheet. This sheet can be used on the upper limb or lower limb and is positioned as follows. One side of the sheet is labelled, indicating which side should face the patient. With the correct orientation established, the sheet is unfolded, again with care taken not to cause any contamination. Once unfolded, the scrub nurse passes the arm through the hole, grasps the patient's hand, and then passes the entire sheet over the entire arm. With the assistant still holding the arm up, the scrub nurse releases the hand and is helped by the surgeon to expand the sterile field. The assistant releases the arm to make space for the surgeon to continue draping. Upper limb draping with an extremity sheet is now complete. Cleaning and draping of the lower limb typically requires 3 members of the OR team, 2 sterile and 1 unsterile. In this film, cleaning and draping is demonstrated for procedures around the knee. A stockinette and U-sheet will be used. The unsterile assistant holds the foot and lifts the lower limb. A large, non-adhesive sheet is placed beneath the leg and is unfolded by both the scrub nurse and the surgeon as shown. In some centres, the preference is to place the ground sheet after cleaning the limb. Once this ground sheet is in place, the scrub nurse and surgeon clean the surgical site, circumferentially and in a systematic manner. The U-sheet is manoeuvred into position by the scrub nurse and the surgeon as shown. Take note of the U-shape for which the sheet is named. With the bottom of the U positioned at the proximal end of the surgical site, the U-sheet is then unfolded and the strips covering the adhesive part removed. With this done, the bottom of the U is stuck down and then the arms of the U are stuck down across each other to extend the sterile field proximally. Take note of how the surgeon and scrub nurse do this one at a time and not simultaneously. With the sterile field extended proximally, the U-sheet is unfolded distally, extending the sterile field in that direction. A large drape is placed over the U-sheet and used again to expand the sterile field proximally. Attention is then turned to the foot. The scrub nurse hands the surgeon a sterile paper towel, which she uses to support the lower limb in the area that has already been cleaned. The assistant releases the leg, allowing the scrub nurse to pass the stockinette over the unsterile foot and ankle. with the surgeon now supporting the lower limb via the stockinette. The scrub nurse finalises pulling it over the leg and sticks it into place. With the stockinette now safely secured to the patient's limb, it is lowered by the surgeon. Draping of the lower limb with the U-sheet and stockinette is now complete.